Hey guys, this is Dr. Marwah. Good to see you guys back. I shall be now talking about questions of the recently concluded FMG December 2020 exam. So let's get started with the very first one for today. In this, he had given a image related to a murmur and he was asking you what type of murmur is present. If you focus on the image, you will notice the fact that the murmur is starting right after S1. The second black line is going to be the ejection click. Ejection click is the time when aortic and pulmonic valves will open. After that, you can see that the murmur is increasing in intensity and then is decreasing. So the configuration that is present here is technically called as ejection systolic murmur. The correct answer to this question will be option number A. Now suppose if you debate with me here that saying, sir, this image was not present, I have a scenario for you, which is that if the murmur was given in the shape of a dome, that is going to be a murmur that will uniformly be heard all through the duration of systole, then we are going to call it a pansystolic murmur that's encountered in mitral regurgitation. In contrast, when you talk about a diastolic murmur, that's going to be heard between S2 and S1. So I'm just going to do a quick configuration here. You see the murmur is starting right from S2 and then is dying down. So this triangular configuration that I've drawn here, which is present in the early part of the diastole, is technically called as early diastolic murmur. So that's how they're going to give you an image of early diastolic. And for late systolic murmur, well, this is S1, this is S2 once again. So after S1, what comes is ejection click. Now what I'm marking before you is called as mid-systolic clicks. Mid-systolic clicks are a feature of mitral valve prolapse, and then the murmur is going to be present. That's a late systolic murmur. That's option number D for you. It's going to be present in mitral regurgitation. Let's just work out the lesions here. Ejection systolic murmur can be remembered by mnemonic by the name of PAS. No, pulmonic and aortic stenosis results in a systolic murmur. Pansystolic murmur is what you read with the MR, TR, and a ventricular septal defect. Early diastolic murmur is aortic regurgitation. There was one more question on aortic lesion per se that I'll discuss in the subsequent part of the discussion. And well, when it comes to late systolic murmur, you read about that with mitral valve prolapse. I would request you to listen to the murmurs discussion with lot of care because most of the time this information will be useful for you. And in this particular exam, there were two questions based on the topic of murmurs, right? The very first lecture that I've highlighted in cardiovascular system is aspects related to murmurs. From there were two questions. So that's obviously a good idea to just go through those. The answer to this MCQ is option number A. Coming to the next question, he is given an image of a person doing a namaste, but you can see the fact that when it comes to the little finger, you can notice some contracture. Well, this contracture could be seen or casually referred to as diabetic stiff hand syndrome. Well, diabetes can cause multi-system involvement. And again, there were two questions on diabetes. One of them is being discussed at the moment. This manifestation is called as diabetic chorioarthropathy. The answer to this MCQ would be called as prayer sign. You can solve this question by exclusion also because Phelan sign and Tillen sign are going to be encountered with respect to carpal tunnel syndrome. I'll just show you an image which will help you understand how do you do a Phelan and a Tinel test. In Phelan that you studied in orthopedics also, you would be using the position of the hand like this, like I'm doing at the moment, or you can see on the screen adjacent to me. And Tinel sign, you will tap on the nerve and you will be able to appreciate the tingling sensation and the paresthesias that are present. Both Phelan and Tinel, which were option number B and C, can be seen in carpal tunnel syndrome. But when it comes to the last option, that was Shamrock sign, that's going to be a feature that is seen with clubbing. If I just zoom in, you can notice the fact that in a normal person, you can definitely notice a diamond shaped area present between the nails in you and me if you tend to join your nails. But in a person having clubbing, because there is going to be a definitive curvature convexity of the nail, so you will notice that this diamond shaped window is not going to be present. In fact, you can see this is now going to be like the dome of let me say a temple, or I can put up an inverted V here. So this that I've shown before you is called as Shamrock sign. And in a way, even if you do not go into the other options, the answer to this question is still straightforward, a prayer sign of diabetic chorioarthropathy, casually called as diabetic stiff hand syndrome. Coming to the next question, he said comment on the diagnosis based on the X-ray and the rapid X and Y descent given on the JVP. You can crack this question even without looking at the X-ray, because rapid X and rapid Y descent has been taught to you in the lecture of JVP for constrictive pericarditis. So this is the kind of a question where you are actually hunting for the answer. Before I mark the answer here, I just want to highlight why answer is not cardiac tamponade, because in cardiac tamponade per se, there will be an increase in the cardiothoracic ratio. There's definitely a cardiomegaly present, but in this X-ray, the heart size looks relatively normal because tamponade is going to be fluid outside the heart, no? So the heart size should increase. But in this case, well, I can rule out option A because heart size is normal. Similarly, I can rule out option number C also because dilated cardiomyopathy will also contribute to increase in the cardiothoracic ratio. Same is the scenario even for hypertrophic obstructive cardiomyopathy. The bottom line is that in this X-ray, you can notice a bit of calcium shadow, right? That white shadow that you're seeing, I'll just zoom it in. That shadow is related to the calcium deposition that is occurring around the heart of this person. And even if you cannot pick up the calcification, what I said was you can simply correct this question with the keyword that is going to be a rapid X and a rapid Y descent. A related MCQ that I can just squeeze in before we go to the next one is that next time he gives you an image where he has given an X-ray and you're not making any sense of it, but if he says rapid X with absent Y descent, then the answer will change to that of cardiac tamponade. The technical details of these I have explained in the main JVP lecture, but I would suggest you to just focus on these core issues. The take-home messages from this particular MCQ, the two that I've highlighted, rapid X, rapid Y, rapid X and absent Y, and you can definitely be very comfortable with these two statements without having the botheration of looking for the findings in the chest X-ray. Going ahead, this was a question about an old man who's having breathlessness and chest pain. On general physical examination, you notice that he was having a high volume pulse. Well, high volume pulse could be either due to fluid overload or it could be valvular lesions of the heart. Blood pressure of 150/70. You will notice the fact that in old people 150 is no big deal, but diastolic is little on the lower side. But let's move on. On cardiovascular examination, the apex beat of the person is displaced lateral to the midclavicular line. This statement that I have mentioned before you, the apex beat is moving away. This tells you that this person is definitely having a cardiomegaly, and at the same time he is also talking about a diastolic murmur being heard in the patient. The usual impression of most doctors is that whenever he will ask you diastolic murmur, I will answer mitral stenosis. That is the feedback that I got from a lot of students, but mitral stenosis is not in the options. So how to solve this question? To solve this question, you need to understand first of all that he's talking about displacement of the apex to the left. So which ventricle is involved in this case? It is the left ventricle that is involved in this case. That means that either the answer will be aortic insufficiency or the answer will be mitral insufficiency, because you see pulmonic and tricuspid I'm ruling out because they're related to the right side of the heart. The main keyword in this MCQ is the first step is to identify which side of the heart is getting enlarged, because the apex bit is displaced to left, so that means it is left ventricular enlargement. Now you need to remember in mitral regurgitation the murmur that is present is called as pansystolic murmur. I drew that also. In mitral regurgitation or mitral insufficiency, we get a pansystolic murmur, whereas in this question, he simply mentioned a diastolic murmur. He even spared you the hassle. I would call this a two-step question, where step one is to identify which side of the heart is involved, then identify the valve. When it comes to aortic regurgitation or aortic insufficiency, the patient will be having a murmur beginning right after the end of S2, because that's when the heart is going to be relaxing, and the technical term for that would be a early diastolic murmur. In the exam, he spared the hassle. He did not even ask you it's early versus mid versus late. It is rather simply the statement diastolic murmur is going to be seen with aortic regurgitation. Because I find a lot of guys having problem solving and remembering such issues, I mentioned two mnemonics in the app. One is pass and second is paid. Had you just gone through these two mnemonics, you definitely would be in a position to crack both of these questions. P is pulmonic, A is aortic. You can see pulmonic and aortic. I'm not writing the word pulmonic and aortic. Pulmonic and aortic stenosis results in generation of systolic murmurs, right? And then you look at the right hand side, PAID. P is pulmonic, A is aortic again. Pulmonic and aortic insufficiency, that's gonna be regurgitation, is gonna generate diastolic murmurs. I have highlighted these mnemonics time and again, though I am personally not a very big fan of mnemonics. I would rather focus on hardcore data, but then if you just go through pass and paid, half your job is done. So I personally feel that these two questions were little difficult kinds, because ideally normally students tend to skip the topic of murmurs, but as I've highlighted, it is high yield, so what's the harm? I mean, just spend 1 hour on it. The answer to this multiple choice question is option number A, aortic insufficiency. Coming to the next one, he said a patient was asked to copy the clock face made by the physician. The image on the right is made by the patient, whereas the one on the left is made by the physician. This is the control. This is what you and me can draw. But you will notice that in this particular patient, he is able to write from 12 to 11, something like that, but he is not having mention of any numbers that should be present on one particular side. Majority of guys have answered this question as hemi-neglect, which is not the correct answer. I want to tell you the fact that this, what we are doing in the patient, is technically called as clock face test. This clock face test is done for evaluation of what we call as visuospatial skills. What I mean by visuospatial skills is that you and me can draw a clock, we can draw the big hand, we can make the smaller needle, we can put in the time. I mean, all of these actions we can do. Or let me put it simply, if I just draw a triangle before you, I draw an inverted triangle before you, I make a star before you can just, I can say, okay, doctor, draw these shapes. Obviously, you can draw these shapes because you can see, analyze, and draw. That is visuospatial skills. But a person who's having loss of visuospatial skills is not going to be able to draw these geometrical shapes, or is not going to be able to copy the clock the right way. So the correct answer for this MCQ is wrongly mentioned by a lot of chaps as hemi-neglect or on various forums. The correct answer for this is constructional apraxia. एप्रेक्सिया का मतलब क्या होता है? एप्रेक्सिया का बेसिक मतलब ही यही होता है that there is gonna be loss of visual, that is you see, you analyze and you can draw. Meaning of the word apraxia is loss of visuospatial skills. On this, the query of most of you young doctors will be, sir, फिर heavy neglect क्या होता है? Well, heavy neglect is gonna be a feature of parietal lobe damage, non-dominant one, where person will use only one hand. Like he will use, let me say, only one hand, that is only left hand to eat. Or if there is food in the plate, like there is rice in the plate, he will eat only from the left side. It's not that he cannot see the one on the right hand side, he definitely can see, but neglect basically means that he's gonna use only one arm, preferential arm usage, or eating from only one side of the plate. And if you ask a person on neglect to draw, then he will draw the clock only half. Let me just show you an image that will make it clearer to you. You see this particular patient that I've shown, I asked him to make a house. You will notice the fact that he has not made whole of the house. Half of the image is missing. In the exam, the image that came, the clock was still round. It is just that the numbers on one side were missing, na? But here you can see that only half of the house is made. Or I asked him to make a flower, and you can see that the petals on one side are missing. That is a feature that is seen with neglect, that he is not going to draw it. But the actual image that came in the exam, and I had a chat with a lot of students regarding this particular image, that's going to be that the clock was made. But yes, the big needle, the smaller needle, I mean, they were maybe switched, and the number entries that should be made at the specified spot, that number entries were not made. The correct answer for this particular question, guys, is A. The message is clock face test can be done in patients of Alzheimer's disease, Huntington's disease. Any patient with neurological illness can be subjected to a clock face test to mainly evaluate what we call as spatial skills. Even if you will Google about it, no, he will use the word spatial neglect. I highlight the fact, instead of writing the word apraxia or loss of visuospatial skills, a lot of internet articles will say spatial neglect. The examiner knows the fact that when you will read this word spatial neglect, you can mix it with hemi-neglect. But as I explained to you, in hemi-neglect, it's gonna be related to only one arm being used, only half side of the plate being used, or only half side of the food being consumed from a plate. Or let me say, if he draws an image, then half of the image would be missing. The answer to this question is option number A. The next question talks about a 47-year-old female with joint pains having difficulty in swallowing dry food items and gritty sensation in the eyes. The first two lines of the MCQ are telling you regarding two presentations. One is going to be dry eyes, that's the gritty sensation, and the second is going to be dry mouth, which will lead you to the diagnosis of this case. She is having normocytic, normochromic anemia. You are familiar with the fact that all rheumatological disorders can contribute to anemia of chronic disease. There is an increased ESR that tells you about inflammatory state. Positive antinuclear antibody. On reading this, a lot of people casually answered SLE, but please remember that antinuclear antibody can be positive in almost all rheumatological disorders. The key word in this MCQ is this antibody by the name of anti-Rho antibody, also called as double SSA antibody, which will lead you to the diagnosis of this case as Sjogren syndrome. You can rule out rheumatoid arthritis because per se it will be involving the small joints of the hands like PIP, MCP and the wrist, and the antibody which is involved here is anti-cyclic citrulline phospholipid antibody. Serum sickness is one that you see with hepatitis B, also called as Arthur's phenomenon or type 3 hypersensitivity. And when it comes to SLE, you should be having antinuclear antibody present plus other features also, no? Like there should be malar rash, there should be photosensitivity, there should be anemia present. None of those classical features of SLE are present in this case. The correct answer therefore is S. Chagran, and the keywords dry eyes and dry mouth, they will definitely help you confirm the diagnosis of this case. The answer to this question is option number A. The next question talks about a 50-year-old chap who's having slight limitation of physical activity, which implies like difficulty in climbing stairs. He's comfortable at rest, like I'm sitting on a chair, I'm comfortable, but ordinary physical activity like climbing stairs is resulting in fatigue, palpitations, and dyspnea. His New York Heart Association grading of dyspnea is. To arrive at the answer of this question, let's go option wise. Option number D, grade 4 implies breathlessness even present at rest. So obviously option number D is off the radar. When it comes to option number 3, that is grade 3 dyspnea, it is characterized by breathlessness even on going to the bathroom. So if a person cannot even go to the bathroom by himself, he cannot even change his clothes. I will use the word marked limitation because you can understand, I mean, if a person is not able to go to the washroom, you might have to put a diaper in the person. On the other hand, when it comes to grade 2 dyspnea, there is going to be a relatively slight limitation in a sense that he may not be able to climb stairs or will climb the stairs relatively slowly as compared to other people of his age. Whereas grade 1 obviously can never be the answer because in those circumstances, there would be no limitation. You see, person with grade 1 dyspnea will only come to you when he will start running. That's when the breathlessness will come relatively early as compared to you and me are running. So you can easily rule out option number A and D in this question. You had to select between 2 versus 3. 3 is gonna be breathlessness even going to the bathroom. So we're gonna call it marked limitation since the MCQ focused on the word slight limitation. So the correct answer to this particular question will be grade 2 dyspnea. That is option number B. The next question talks about a patient with a head and a hand enlargement with gynecomastia and lactation. Well, the head and the hand enlargement tells you that there is excess of growth hormone in this person. That's gonna be acromegaly. But there is also a gynecomastia and a lactation occurring in this patient. There's a galactorrhea occurring in this patient. This implies that prolactin will also be increased. You see, lots of time person can be having a pituitary adenoma. The pituitary adenoma can be having excessive growth of two cells. One is going to be somatotroph that will produce growth hormone. Second will be excess production of prolactin by mammotrophs. So this particular person per se, or this case that has been given to you in the exam, is actually a somatomammotrough adenoma. It's a pituitary adenoma causing excess production of these two hormones. And where is it located? It's located in the anterior pituitary. You see, posterior pituitary anyway cannot be the answer because that is where you study about diabetes insipidus only, na? When it comes to hypothalamus per se, I'm ruling that out because hypothalamus controls the pituitary. In this condition, the main problem is excessive growth hormone as well as prolactin. And adrenal gland is anyway a dummy choice here. The correct answer to this question is option number A. The basic concept is that patients with acromegaly can also be having a galactorrhea. They can also be having excess of prolactin per se. So don't be under impression that galactorrhea is seen only with a prolactinoma. It can even be seen with acromegaly. As I said, I mean, you could be having a somatotroph adenoma, you could be having a somatomammotrough adenoma. The answer to this question is option number A. The next one was a piece of cake. It talked about an alcoholic having diarrhea, dermatitis, and dementia. So you obviously know about the 4 Ds. The 4th D would be death, which is obviously not mentioned here. But if you incorporate the 3 Ds in alcoholic, this would tell about niacin deficiency. The answer to this question would be option number B. The next question says, in a case of head trauma, which fluid is not given? You see, the bottom line is, and I've highlighted this in the discussion of fluids, that whenever a person is having a CNS injury, whenever a person is having a raised intracranial pressure, then you should be giving hypertonic fluids. Hypertonic fluids can be like mannitol. Hypertonic can be like 3% saline. You see, if a person is having swelling in the brain and you will give 3% saline, it will suck out the water, it will remove the water from the brain, so the swelling will reduce. Both 3% saline and mannitol are hypertonic fluids, HYPER, hypertonic fluids. In a person having raised ICP, you are not supposed to give hypotonic fluids, and the hypotonic fluids is 5% dextrose. The correct answer to this MCQ is option number A. You will give hypertonic saline, you can give mannitol, you can give normal saline, ringer lactate also, because they are isotonic solutions. When it comes to these two, they are basically crystalloids, they would be isotonic, so can be given for replacement. But because 5% dextrose is a hypotonic solution, if you are gonna use it, what's gonna happen? It's gonna rather contribute to increase in the brain swelling. Hypotonic fluids are absolutely contraindicated in a patient of raised ICP. If you're going to do that, it's going to cause worsening of the cerebral edema component of this patient. The basic concept you need to understand is swelling in the brain, suck out the water, decrease the pressure in the brain. And if you give a hypotonic fluid, that's the carry home message for you, then there could be worsening of cerebral edema component coming in. The answer to this question is option number A. Moving to the next one. It's talking about a child from a low socioeconomic strata who has been brought with fever and abnormal behavior for last 3 months. The child is in altered sensorium for past 1 week. So there's definitely a CNS event that has occurred in this child. The illness of this guy or illness of this low socioeconomic child is spanning over weeks to months. On examination, neck rigidity is present. So we are definitely talking about meningitis here. The CSF is showing increased lymphocytes. You see, if you look at the data here, a child from low socioeconomic strata of the society with long-standing neurological illness is going to be tubercular meningitis. In tubercular meningitis, the highlights are that lymphocytes are always increased. I've always highlighted whenever you are doing a CSF microscopic examination and in an Indian exam, if he is always going to talk about lymphocytes which are relatively increased, this tells you the fact that the diagnosis is always to be thought in terms of tubercular meningitis. The bacteria will consume the sugar, so CSF sugar will be lesser. Normal CSF sugar is 2/3 of the blood sugar. Here it is low. Normal protein of CSF, I think everybody knows that normal protein in the CSF is gonna be how much? Normal protein in the CSF is something in the range of 50 to 150 milligram percent, but in this patient it is almost double. So because there is a inflammatory process occurring here, the antibodies are being produced. No, antibodies are gamma globulin. Gamma globulin is protein, no? So the protein component is going to be increased. So all the features are going to go in favor of tubercular meningitis, especially in an Indian exam when you have a long-standing neurological illness and CSF lymphocytosis is present. TB is the first answer. Well, why the answer is not viral meningitis? Because viral meningitis will always be having relatively a short duration. Viral meningitis is caused by like enterovirus, so it's gonna be illness of 2-3 days followed by nuchal rigidity. Fungal meningitis is found in immunocompromised patients like a AIDS positive patient. There was a question on cryptococcal meningitis also in this time's exam that I'll show in the subsequent part of the discussion. And Neisseria meningitis will again be having a short duration of illness. Neisseria meningitis will also be having neutrophils present in the CSF, so you can rule out the remaining options. The correct answer to this question is option number C. The subsequent question talks about a 30-year-old patient presenting with acute abdomen. The X-ray abdomen was done in a standing position and you definitely can make out gas under diaphragm. This tells you the fact that this person has had a perforation peritonitis. And well, what do you do for a perforation peritonitis is what he has asked. Option A says drain the peritoneal fluid. Well, that's just a dummy choice, guys. In peritonitis, you need to do exploratory laparotomy. The correct answer to this MCQ is option number C, and the remaining options I think are dummy choices and can be easily excluded. Why did he have a perforation? Then I can highlight the fact that this could be an undiagnosed duodenal ulcer, because most of the time undiagnosed duodenal ulcer can perforate and can cause a perforation peritonitis. The answer to this question is option number C. The following CT abdomen shows, so you definitely can visualize the liver. You can definitely visualize the kidney parenchyma, and that is united. So this is going to be a horseshoe kidney. The answer to this question is option number C. PTA spot diagnosis can be picked up very easily. You can see the U-shaped curvature of the kidney, which can definitely be traumatized as well. The answer to this question is horseshoe kidney. The next question talks about diagnosis based on X-ray abdomen image. You can definitely see two bubbles present here. The moment you see a newborn baby's X-ray, and then there are two bubbles present here, I think that's a spot diagnosis. Double bubble appearance is a feature of duodenal atresia, so you can easily identify it. In diaphragmatic hernia, there would be herniation of bubble into the chest. Transient in a newborn, he will give you history of cesarean section followed by respiratory distress. But since no history is given and two bubbles are present, so that would be a duodenal atresia. A 60-year-old due to restricted ambulation and prolonged bed rest due to acute lumbago. Lumbago would mean severe backache presented with severe pain in the left leg below the knee. You see, the initial problem of this person is that person was having some problem in the back. So the person can't move around, and because there is prolonged bed rest in a person, you can notice the extreme swelling now is occurring even in the calf, also in the thigh. The swelling has progressed. If you compare the two legs of the patient, there's a marked increase in the girth of the patient. This is definitely a feature of soleal vein thrombosis, and the soleal vein thrombosis will extend upwards up to towards the femoral vein also. This particular person is having a deep vein thrombosis. The key word in this MCQ is prolonged bed rest. Prolonged bed rest results in stasis of blood and contributes to this kind of a manifestation. So I personally feel this was an easy one. The next question talks about a cricket player who was hit on the head by a cricket ball. He was fine, but then he collapsed suddenly. He woke up to play the match very brilliantly, but later was found unconscious in the dressing room. The question is basically talking about lucid interval. You see, the moment the ball hit the head of this guy, he became unconscious. LOC means loss of consciousness. After which he woke up after, let me say, 1 or 2 minutes. So all the players in the field and the umpires also thought that he's okay, and he played the knock very well. He maybe scored half century or even a century. But when he went back to the dressing room, his friends thought that he's sleeping and he had died. Such kind of a situation where you get consciousness between two periods of unconsciousness is what you casually refer as lucid interval, and this is a classical presentation of an extradural hemorrhage. Anyway, when we talk about a biking accident, a guy hitting the side of a concrete road, not wearing a helmet, a cricket ball impact, it's always gonna be an extradural hemorrhage. The next question talks about a baby boy brought at 3 weeks of age with recurrent episodes of non-bilious vomiting. You definitely can notice a lump which is much above the umbilicus of the child. You see, when you talk about gender being boy, presentation at 3 weeks and non-bilious vomiting, the diagnosis will straight away be congenital hypertrophic pyloric stenosis, for which you do a Ramstead operation. The next question talks about a 25-year-old person who is presented to you with severe right iliac fossa pain and tenderness. He was operated for acute appendicitis when the surgeon has noted a defect 2 feet away from the ileocecal junction, which is the key for this question, because you can definitely apply the rule of 2 here and come to the diagnosis. Apart from this, also notice the fact that this is the mesentery and the lesion is present on the anti-mesenteric border. So there are 2 points provided in the question. One is going to be 2 feet away from ileocecal junction. Second is anti-mesenteric border, which will narrow down the diagnosis of this question as Meckel's diverticulum. The answer to this question is option number D. The next question talks about an 8-year-old child who's presented with a localized painless swelling growing in size since childhood. The location is at the lateral canthus of the eye. So first you need to make a spot diagnosis. Well, this is not a lipoma. This is usually not the location for a lipoma. This would be a dermoid cyst. Once you get the diagnosis right, you just need to remember that for the management of this condition, you need to go for excision. Chemotherapy is anyway off the radar because chemotherapy is given for cancers. We cannot say that this is a cancer. The first differential diagnosis is a dermoid cyst. Intralesional steroids is what we use for management of keloid, so I'm ruling that out. You have to select between excision and radiotherapy. Most of the time, if the lesion is causing a disfigurement, the first approach that we would like to do in this child to prevent a disfigurement would be a excision, because as it keeps on growing bigger, it will hamper the lateral view of the person. The answer to this question is option number alpha. The next question was a very interesting one. When I spoke to students, they told me that they definitely could see that the hands of the person were more or less normal, the nails component, but you definitely can notice the convexity in the nails of this person. This convexity in the nails of the person will help you in making the diagnosis, which is going to be clubbing. Well, cyanosis is very difficult to make up in an Indian population because we are dark skinned as compared to Americans. So it's highly unlikely that they gave cyanosis in the image, as some of you were saying, because anyway in a dark texture person, cyanosis will usually not be seen. So it's unlikely to be mentioned. For Raynaud's phenomenon, they have to give multiple images. Raynaud's phenomenon is going to be a color sequence change. No, it's going to be white, then it's going to be red, then it's going to be, the color change sequence will occur. So Raynaud's phenomenon diagnosis can only be made on the basis of multiple images. A single image cannot diagnose it. So anyway, that is ruled out. And pallor, well, checking for pallor, no, why would pallor be checked on the hands? Pallor is mostly checked with respect to the conjunctiva, or the palmar creases can be used for checking for pallor. So the correct diagnosis from my perspective for this condition is clubbing. The next question talks about a 2-year-old child who fell down while playing with a sibling and is developing a big hemarthrosis. You can notice that hemarthrosis is always a presentation of hemophilia, and he's asking you what is the possible etiology. That's going to be factor 8 deficiency. Von Willebrand disease, why it is not the answer for this question, is basically because von Willebrand disease mainly presents with prolonged bleeding after dental extraction. Like, he will usually begin the question by talking about a girl, and he will say that this girl was, let me say, having a wisdom tooth, or she's having a tooth impaction, right? Or she's having a cavity in the tooth which is needs to be removed because it hurts. So prolonged bleeding after dental extraction Especially if the question talks about a girl child, is going to be thought in terms of Wall-Willebrand disease, for which Restore-Scene aggregation test is done. But in this particular case, it's a standard presentation of hemarthrosis, which is seen with clotting factor deficiencies. The take-home message for you is, whenever platelets are less, you guys get petechiae and purpura. Whenever clotting factors are less, you get presentation of hemarthrosis. The answer to this question is option number B. Well, what is parahemophilia, guys? Which clotting factor deficiency causes parahemophilia? This is itself a question. Parahemophilia is due to deficiency of factor 5. Hemophilia A is factor 8, hemophilia B is factor 9, hemophilia C is factor 11. But if it is 5 deficiency, we call it parahemophilia. And Glanzmann thrombasthenia is where the platelets will malfunction. The platelets are not going to be able to form a clot initially, because the first step is vasoconstriction followed by platelet aggregation. That platelet aggregation part would be malfunctioning, would be misbehaving. So that's why Glanzmann thrombasthenia occurs. The answer to this question anyway is option B. The next question talks about this 10-year-old girl who's having continuous menstrual bleeding for 10 consecutive days after a first ever menses. Well, when the menstrual cycle starts, it could be irregular. At the same time, the bleeding can be excessive, but definitely 10 days is little on the higher side. So the mother is worried and she's asking, doctor, any test you would like to do? I want to tell you the fact that this could either be a presentation of Glanzmann thrombasthenia, which is related to platelets. The platelet quality is defective, that the platelet count is normal, but they are going to misbehave. No, as the name is asthenia, that means the platelet is not functioning properly, and therefore this could be the reason. The second differential diagnosis in my mind for this condition can be Bernard-Soulier syndrome. If you listen to the discussion of either the pathologist or mine in hematology section, I have described that both of these conditions will either present after excessive bleeding after any kind of minor or major surgery, or for that matter of fact could be in the form of menorrhagia or excessive bleeding at the time of onset of menstrual cycle. So the test that we do for this is platelet function assay, PFA 100. Now a lot of you were under impression, a lot of people actually could not even recall option number D, and people said PFA was not in the options. So I asked them, okay, what do you think was in the options? Then one of the chaps said that, sir, I think that it was KFT in the option. If the question is given as what I've written now before you, if PFA 100 is not in the options, then the answer would be given as A, blood coagulation profile. However, if blood coagulation profile and PFA 100 both are given, then the correct answer is option number D. I repeat that again, the correct answer for this question ideally should be considering these two differential diagnoses that I've written. So platelet function analyzer should be used, PFA 100 should be used. That helps you identify these two disorders which are related to quality of platelets being defective. If not in options, then the standard blood coagulation profile should at least be done to reassure the mother and obviously the child also, which she'll be worried because she's bleeding, and that would definitely be a scary situation for the child. The next question was a spot diagnosis. You can definitely notice, though this is not the exact image, but you can definitely notice that there was a presence of purple striae on the anterior abdominal wall of the patient. The striae are present even on the buttocks, even on the breast of the person. You can also notice the centripetal obesity component. Both of these features, purple colored striae and centripetal obesity, is what you encounter with Cushing syndrome, where you have excess of cortisol in the body. The answer to this question is option number A. PCOD cannot be diagnosed by looking at a patient, so ruled out. Acromegaly will be having excess of growth hormone, so there would be increase in the size of the hands, and already we have discussed a question on acromegaly in the earlier part of the discussion. Con syndrome will be having excess of aldosterone, so there should be mention of hypertension. You cannot diagnose Con syndrome by looking at the patient. The spot diagnosis which is present in this case, including this hump you can see, no? I mean, if I just zoom in, you will notice that the diagram has been made like this, that you can see a hump at the back. That would be buffalo hump. So even if this is not the exact image in the exam, the point of mine is, if you're having an obese lady, you're noticing the purple color stripe, if you're noticing the buffalo hump or just a significant weight gain, then you need to think in terms of excess of cortisol, and that would be Cushing syndrome as the answer. The next question talks about a guy who comes to OPD with complaint that he develops pain in the penis during erection and cannot have sex. What is the likely diagnosis? Option A is paraphimosis. You see the problem in paraphimosis, I'll explain from the diagram. You can see that this is the representation of penis and this is the foreskin. So what's going to happen in paraphimosis is that when this guy will pull back the foreskin, right, He's pulling back the foreskin either maybe because of masturbation issues, or pulling back the foreskin mainly because he wants to have a sexual intercourse. Once the skin will go back, it will get stuck here and the distal part of the penis will swell up. This image that I've shown here before you is a presentation of paraphimosis, which is a medical emergency, and the person will have to come to your hospital for the treatment of this condition. The basic point is, in paraphimosis, once the skin goes back, it's not going to come back. It's not going to come back. So this is definitely not the presentation of this guy, because the question is simply saying that he develops pain in the penis during erection. He cannot have a sexual activity. I'm ruling out paraphimosis, which is a medical emergency. Once the foreskin goes back, it's not going to come back. Let's go back to another option. That's going to be phimosis. So phimosis would simply mean that there would be a narrowing present. So he might be having a urinary dribbling. I mean, the usual presentation of people with phimosis would be dribbling of urine in an infant. Hypospadias is again ruled out because the location of the urethra would be inferiorly, as you can see in this image. The diagnosis of this patient is what is shown in this image also. You can see that the penis of this person is bent. There is a calcification that is occurring in the penis of this guy, that is called as Peyronie's disease. Peyronie's disease always presents with these complaints that I've highlighted, so these patients will not be able to have normal sexual activity. The answer to this question is option number delta. The next question talks about a patient who underwent a hysterectomy and is now having an abdominal distension and abdominal pain 3 days post-operatively, which electrolyte imbalance will be present. In any patient, if there's gonna be a post-operative scenario of abdominal distension, then the electrolyte that is responsible for this, which is causing ileus means paralysis of the gut, is mainly due to deficiency of potassium, and potassium will be lost in these patients, because you see, any patient undergoing surgery, there is a possibility that the bowel will get paralyzed, and these patients might be having loss of potassium in the GI secretions. Post-operative abdominal distension, the leading cause of this is hypokalemia. It will cause gross abdominal distension. It will cause ileus. The answer to this question is option number C. Coming to the next question, he's talking about a 3-year-old child having a progressive anemia. On examination, there's a splenohepatomegaly. Normally, you read about hepatosplenomegaly, no? But splenohepatomegaly is always a feature of thalassemia. There is also prominent malar eminences. I mean, the moment you read it, no, there is target cells which are present. So there are multiple inputs which are given in this question for your diagnosis. Target cells are there. Prominent malar eminences would mean chipmunk facies. And because there is anemia present along with this, organomegaly present in this, so the correct diagnosis of this guy is option number A. The remaining options are anyway dummy choices. I mean, the keywords are target cells, chipmunk facies, splenohepatomegaly. In all hemolytic anemias, you have a splenomegaly. In all hemolytic anemias, you have a splenomegaly, but splenohepatomegaly is always given in thalassemia. It could be beta or alpha thalassemia depending on the ethnicity of the patient. Coming to the next question, he's talking about a 30-year-old woman having progressive dysphagia. On examination, she's having thickening of the oral mucosa and a leather-like skin. Now, that's the key in the question. The leather-like skin would imply that there could be a presence of fibrosis. She is also hypertensive. She has limited exercise capacity due to lung fibrosis. So the bottom line for this question is fibrosis everywhere. Fibrosis in the skin, fibrosis in blood vessels, fibrosis in the lungs of the patient. What is the diagnosis of this person? The answer would be given clinically as scleroderma. You see, scleroderma is an autoimmune disorder which is characterized by 2 words. The sclero basically means the fibrosis component coming up. HLA cardia will only be having complaints of progressive dysphagia. But in this person, apart from dysphagia, so many other features are given. So that's why HLA cardia is ruled out. Post-cricoid dysphagia is the alternative terminology for what we call as Plummer-Vinson syndrome, where we have iron deficiency anemia and chylionicea, and there's no mention of any iron deficiency anemia and chylionicea in this question, so I'm ruling out option number B also. Peutz-Jeghers syndrome is anyway ruled out because that would be having development of melanosis, that is mainly around the lips. There's also polyps which are present, which are called as hamartomatous polyps, none given in this question. So even by exclusion, you can solve this question. I know this was relatively a long one, so people tended to waste about 3-4 minutes in this. But the bottom line was multi-system involvement. You see, whenever you read a question of a woman and talks about multi-system involvement, it has to be a question from rheumatology. I repeat that again. Woman multi-system involvement, you have to think in terms of rheumatological disorders because they are the ones which have multi-system profile. And one of the keywords was leather-like skin thickening of the oral mucosa. So that helps you facilitate your diagnosis as scleroderma per se. And I hope you recall the antibody for this condition also. The antibody for this one is called as anti-topoisomerase antibody. In fact, right now I have taught you two antibodies, right? If you're planning for the 2021 session, two antibodies are taught you are anti-Rho antibody for S. Sjogren and anti-topoisomerase antibody for scleroderma. So get the antibodies right in rheumat. You see, I've covered in rapid revision the rheumat is only 1 hour, but that 1 hour will crack these two questions for you. I said the strike rate is two questions spot on in this particular exam straight away if you get the antibodies right. And I've highlighted this again and again that if you get in rheumatology, if you just focus on the antibody details, you are bang on spot, because otherwise the multi-system involvement is so much that you have to actually see patients, and most of you know abroad, they don't show you patients, and in COVID scenario anyway the clinical exposure will be much limited. The answer to this question is option number D. The next question talks about a nurse who has developed a prick from a HIV positive patient. He did not ask about post-exposure prophylaxis. He said, what test will you do to identify the transmission of infection? The point is that once she will get the prick, immediately the ELISA test will not become positive now. Even the 4th generation ELISA test will become positive on the 22nd day of illness. Let me say day 0 is the time she got the prick. Even if you're doing the most advanced ELISA test for HIV infection, the 4th generation ELISA with a sensitivity of 99.5%, the test usually turns positive on the 22nd day of her acquiring the infection. So this means that she's gonna be in lot of emotional trauma for these 3 weeks, because you're gonna tell her, I'm gonna tell you whether you got the disease after 3 weeks. She says, sir, tell me now. So how do you pick up the HIV infection in the window period was the concept behind this question. In fact, if you listen to the discussion of hepatitis B and HIV, I've highlighted the aspect of window periods. If you want to diagnose this HIV infection in the window period, you need to go in either for PCR, which is not in the options. So what will you do? You will do a P24 antigen. I repeat the statement once again, take it on yourself rather than on his nurse. You got a prick from a HIV positive patient, and if a doctor tells you that I'm gonna tell you whether you got this infection after 1 month, हिंदी में आपको कहता है कि 1 महीने बाद आइयो, फिर बताएंगे तुझे डायग्नोसिस कि तुझे HIV इन्फेक्शन हुआ या नहीं हुआ. तो आप इमोशनल स्टेटस, आई कैन टेक इट माई सेल्फ. आई विल बी अ नर्वस wreck waiting for 1 month for somebody. I'll go to the doctor and say, don't you have technology? You medical people call yourself so advanced, so don't you have technology to pick up the infection early? So what will you do? You're gonna do a PCR. Now, because PCR is not given, you will do a P24 antigen in this case. The 3rd generation ELISA will take 3 to 6 months. I repeat the statement once again. In fact, I'll just use a different color to highlight it. The 4th generation ELISA can pick up the infection as early as 22nd day of infection. The older ELISA, which is lots of time used in Indian laboratories, it has a lesser sensitivity, something in the range of 98 to 99%. The 3rd generation ELISA usually turns positive after 3 to 6, sometimes even months, not even weeks. So imagine the trauma in the mind of this nurse, in the mind of this doctor, that you're gonna say कि 6 महीने बाद बताएंगे तुझे infection हुआ या नहीं हुआ. I want a spot diagnosis. So it's either a PCR or a P24 antigen. The correct answer to this question is option number C. The next question was fairly an interesting one. In this, there was a boarding school in which multiple kids are eating from the same canteen. Now, all of them have developed icterus. They have developed poor oral intake, jaundice, abdominal pain. So what I'm thinking here is that because they are, one, talking about child, and second, they're talking about all of them developing jaundice. So we are talking about an epidemic of hepatitis A. You are aware of the fact that hepatitis A is transmitted by fecal-oral transmission. In adults, fecal-oral hepatitis E is the commonest infection, but in pediatric age group, especially in India, it is hepatitis A that is common. I repeat that statement once again. If the question simply says, what is the commonest virus contributing to fecal-oral transmission and causing acute viral hepatitis on a global basis, it is hepatitis E. But in children, and especially in India, it is hepatitis A, and anyway, there was no hepatitis E in the options. So you want to diagnose acute hepatitis A infection in this person. So you will be doing IgM class of antibody against hepatitis A. You obviously can rule out hepatitis B options in this question because there is no per se chances of hepatitis B in this case, because we're talking about fecal-oral. We're not talking about a blood transfusion. We're not talking about any parental route of inoculation. IgG antibody is for long-standing infection, and anyway hepatitis A does not have chronic hepatitis. Even if you do not know this fact that hepatitis A does not have chronic, you still have to diagnose an acute infection. I've highlighted time and again in my lectures that whenever it is gonna be talking about acute infection, how do you diagnose? Either a PCR or IgM class of antibody to the offending antigen. If that IgM class of antibody is present, cool. That would be the diagnosis for our case. The answer to this question is option number alpha. The next question was a repeat one. The question said amyloid protein deposition in a person undergoing recurrent hemodialysis is, the answer would be A beta 2 amyloid. You are familiar with the fact that A beta is seen with Alzheimer's disease. When it comes to A beta 2, that would be seen in patients of undergoing hemodialysis. That will explain the dialysis dementia component also, no? The question can also be modulated next time. That's why I'm writing it. If the question says which amyloid protein contributes to dialysis dementia, the answer is going to be A beta 2. But senile dementia, if written in the question, the answer would be given as option number A, that is A beta. ACAL is what you read with, I hope you recall that, medullary carcinoma thyroid. And medullary carcinoma thyroid has been taught to you in the literature of Sippel syndrome, which is also called as multiple endocrine neoplasia type 2. And AL is the one which is overall the commonest type of amyloidosis. No, that is the one that you deal with multiple myeloma. The correct answer to this question is option number B. Dohlmann operation is done for. Well, I could have left this question mainly for the surgeon, but I decided to incorporate this mainly because we usually skip this. A lot of guys messed up this MCQ. Dohlmann's operation is done for handling Zinker diverticulum. And Zinker diverticulum would be option number A, that is a pharyngeal pouch. The remaining two malformations will require a dilatation. You see, in esophageal web, I'm not going to do any operation in the patient. If there's an esophageal web, I can dilate it. I can use a boogie and I can dilate it. So most of the time in a esophageal, I would say web or a Schatzki's ring per se, we send in a boogie. That's a small device which is deployed and dilates the narrowed esophagus. Option number B and D can be ruled out by what I just highlighted. You are left with anal stenosis, for which again you need to do a dilating procedure, and then is pharyngeal pouch. So I said it's a difficult one, but then at the same time we need to be mentally prepared for having a balance of difficult and the easy ones in the same paper. The answer to this question is option A. The next one says what is being amplified in reverse transcriptase PCR for COVID-19. Even if COVID-19 was not there, you see, even if it's any RNA virus also, no, it would be converted into DNA, and the DNA is the one that is amplified. So the answer will be option number A. The next one talks about a young lady having recurrent headaches and blurring episodes. You see, when you read about recurrent headaches and blurring episodes, it could be stroke. Workup of the patient shows grossly elevated platelet count with normal WBC and RBC count. So the problem is thrombocytosis. The platelet count is more in the person. As a result of it, there could be development of clot formations with respect to ophthalmic artery, with respect to cerebral circulation. So there could be headaches. Option A says polycythemia vera. In this condition, it is mainly the RBC count that is increased. This occurs due to JAK2 mutation. No, it's mainly the hemoglobin that will be increased. So obviously in this question it is not the answer, because the question talked about platelet count elevation. Chronic myeloid leukemia always presents with massive splenomegaly. In chronic myeloid leukemia, the platelet count usually is normal or slightly increased, but never grossly elevated. And anyway, the main presentation of chronic myeloid leukemia is gonna be asymptomatic. Most patients of CML, unless and until they go into blast crisis, no, they don't have any symptoms initially. They might be having bit of constipation due to splenomegaly, early satiety due to splenomegaly, but as such, CML does not have any symptoms initially. Essential thrombocytosis is the answer to this question because the platelet count is elevated. You see, this is a myeloproliferative disorder. Myelofibrosis, the word is fibrosis, it will produce pancytopenia. So suppose you are not aware of the specific answer spot on, you could have used exclusion in this particular question as I have deployed here, and I personally would suggest you to develop exclusion skills for future exams, because most of them are going to be as like this, only clinically oriented. I mean, instead of simply asking you platelet count is grossly elevated in, the answer would be given by you easily then as essential thrombocytosis. He just gave you a scenario of a person having CNS manifestations, because they would be a sluggish circulation. This would be a prothrombotic state. You see, platelet count is more, so there would be microthrombi that would be developed in this case, and those microthrombi can affect the ophthalmic artery, so visual blurring. Cerebral circulation affected, headaches could be occurring in this patient. These patients can develop features of stroke. That is why we need to give aspirin to these patients on long-term basis. We need to give pentoxifylline for these patients. And from pharmacology, I think you are aware of the fact, no, that the drugs that we use for this condition are anagrelide and hydroxyurea. Hydroxyurea especially used in blood cancers to decrease the counts. Like in this case, the platelet count could be 10 times the normal. So to decrease the 10x platelet count, you will be using the following drugs for management of this patient. In fact, I just taught you additional information in this question. Drug that is used for increased cell count, like increased platelet count, increased white blood cell. In blood cancers, we can give hydroxyurea to control the cell counts. The answer to this question is option number C. The next question talks about a person with gingival bleeding and recurrent infection. That talks about possibility of platelets being hampered in the person, right? And at the same time, the TLC of the person could be lower. Per abdomen shows a hepatosplenomegaly. So what are we suspecting? We're thinking in terms of a blood cancer. The highlight was that on a peripheral smear, blasts are present with distorted nuclear cytoplasmic ratio. He is himself saying blast, that means it is a blood cancer. And 70% of the cells were myeloperoxidase positive. You know, MPO positivity is for myeloid leukemia. Because this is an acute presentation, the correct answer to this question will be acute myeloid leukemia. Chronic myeloid leukemia presents with splenomegaly. Here it is given hepatosplenomegaly, so I'm ruling out option number A. Chronic lymphocytic leukemia usually develops after 70 years of age, and the presentation of the commonest blood cancer is lymphadenopathy, whereas in this question it was hepatosplenomegaly. Acute lymphoblastic leukemia will present in a child. You can see in this case the presentation is at 50 years of age. So you can rule out the remaining options by age of presentation itself and just getting the main features right. When I've discussed blood cancers, I have discussed towards the end a table. That table is a summary that I want you to remember for all the blood cancers, because there are so many with so many overlapping features in the exam, you may not be able to remember them all. So I would suggest you that once you've done your pathology, hematology, just go to the medicine section, listen to that at 1.5, not 2x as a lot of guys do that. 2x, the voice is croaky, you just waiting for the lecture to get over. Do it at 1.5, maximum 1.8x, and try to focus on the notes at that point of time, and you would get a better insight into blood cancers. I would suggest hematology to be done very thoroughly, because always in your MC exam, always in this screening exam, they've always focused on the hematology section. The next question talks about a 60-year-old male. He's presented with low backache. X-ray shows osteoblastic changes. Now, people who miss this word osteoblastic, you see, when you think about osteolytic, that's going to be multiple myeloma. But it was osteoblastic changes, so it's definitely not multiple myeloma. The answer in this case would be given as carcinoma prostate. When it comes to multiple myeloma, it will cause lytic lesions, so osteolytic. Pot spine will result in reduction in the joint space and vertebral dissection also, but mainly the presentation of pot spine would be decrease in the actual height of the person, because the space between the joints tends to reduce. And renal cell carcinoma again produces osteolytic secondaries. In this particular question, there are two options where osteolytic secondaries are present, option A and option D. And because the question was saying osteoblastic, that is why the answer is carcinoma prostate, or can be breast cancer also. The next question talks about a child presenting with difficulty in eating due to jaw swelling and enlarged cervical lymph nodes. The lymph node biopsy is present here. The biopsy finding of this patient is starry sky appearance. And along with that, you can notice that the child is having a jaw swelling. That is itself telling you that this presentation is that of Burkitt's lymphoma. The correct answer for this question is option number delta. The main highlight in this question would be, because he is talking about a child per se, so it cannot be a Hodgkin's lymphoma, because Hodgkin's mainly develops in the later age group. Infectious mononucleosis should be having splenomegaly. You can rule out safely B versus C. If the confusion was, it was between Hodgkin's lymphoma, where the Reed-Sternberg cells, or Burkitt's lymphoma per se. I've discussed this question with the pathologist on my YouTube channel, Dr. Marwah Live, where I have highlighted this question. In fact, just one day before the exam, we had a live session and we discussed majority of hematology. In fact, whole of hematology and large scope of pathology was covered on that day. And from that, we had a very good strike rate, but I don't want to, at the moment, boast about or talk about the strike rate of the questions. It is just that for you to understand that 2-hour discussion that is present on my YouTube channel, I want you to read the hematology section and pathology very thoroughly. If you go in hemat, in pathology, and then read the medicine section, you are bang on spot to surely get at least 10 questions right in the exam. That's a huge difference. That makes a huge difference to your self-esteem, makes a huge difference to your final scores. Coming to the next question is talking about a 35-year-old female with 1-year-old history of neglected dysuria. That means she is having this burning micturition or suprapubic pain, hesitancy, and intermittent hematuria also. Comment on the diagnosis of the X-ray pelvis. The image may not be same, but you can definitely see a white shadow in the pelvis. This white shadow in the pelvis would be a bladder stone in the person. Prostrate calcification, I'm ruling out because we're talking about a female patient, no? And even if it was a male given in the exam, no, prostate calcification can't be so big. Bladder cancer does not have calcification. Womb stone, what is a womb stone? It is a calcified fibroid. But then womb stone also develops in postmenopausal age group, no? I repeat the statement once again. Option number D, womb stone is actually a calcified fibroid, and fibroids become calcified in postmenopausal age group. Whereas in this case, the age group of presentation is about 35 years of age. So option number D can also be ruled out. Our patient is 35 years of age. She is having local damage to the bladder by this big stone, which is contributing to the manifestation. So you can do a CT pelvis, confirm the diagnosis, and then remove the stone. The answer to this question is A. The next question talks about a 60-year-old man with lower urinary tract symptoms. LUTS is lower urinary tract symptoms like dysuria, burning micturition, suprapubic discomfort. Ultrasound abdomen shows a prostate size of 55 ml. Normal prostate size is gonna be approximately maximum 30 ml or lesser, but in this case the prostate is almost reaching 2x of normal. Post-void residual urine. In normal person there is minimal, maybe 10 ml, 20 ml residual urine, but here it is a huge 150 ml. PSA was grossly elevated. So what are we talking about? We are talking about this person having a possibility of a prostate cancer. PSA values in this person are almost 4 times of normal. So I need to think that if it's a prostate cancer, I need to go in for a biopsy. Option A said CT scan. CT scan cannot tell you whether there's a cancer or not. No? PET scan will tell you metastasis. But at the moment, metastasis may not have occurred. So I'm ruling out B. Bone scan is done for bony metastasis, no? The answer for this question is option number D, transrectal ultrasound guided biopsy. Well, there are obstructive symptoms present in this patient. The points which are making me think in terms of a biopsy for this patient are: one, there is presence of obstructive symptoms. Lots of time prostate cancer might actually straight away metastasize to the lumbosacral plexus and lumbosacral area. They might be even damage to the bones causing low backache. But thankfully in this guy, the obstructive symptoms were noted initially. Along with this, grossly elevated PSA is present in this guy. So considering the scenario of an old man with obstructive urinary symptoms, elevated prostate specific antigen, and even a post-voidal residual urine. In fact, the first clinical diagnosis of mine for this person would be BPH, that is benign prostatic hyperplasia. But because it is benign, I'm not worried about it. Because it's a cancer, I'm worried about it. So wherever in doubt, it's always an advantage to given the benefit of doubt that we should always rule out a malignancy. Out of the options that are given in this question, the best one that fits is a transrectal ultrasound guided biopsy in lieu of grossly elevated PSA. The next question could not be recalled by most people. In fact, a lot of people just remembered orchitis and were thinking in terms of mumps, but there was no mumps in the options. A person from northeast came to the clinic with complaints of fever, neuritis, orchitis, and lymphadenitis. Which of the following is a possible etiological agent? West Nile virus is mainly found in United States. West Nile virus is found obviously in Africa and then even in Canada. So foreign travel history should always be given. West Nile virus causes encephalitis. I mean, this disease is gonna be, or this organism is gonna be responsible for encephalitis. So history of foreign travel and traveling to wildlife areas is should be given for you to make a diagnosis as option number A. Infectious mononucleosis mainly presents with fever, with sore throat, and then a splenomegaly. It is unlikely to be a diagnosis of infectious mononucleosis of this patient because the classical features are not given. You are left between brucella and tularemia. In tularemia, it is mostly the history given is of a hunter. This guy was hunting down, let me say, rabbits. When he killed the rabbit and he was skinning the rabbit, the ticks that were living on the body of the rabbit, now they need blood, they need something to eat on, so they bit this hunter on his hand. So Ester formation, you read about Ester formation with respect to anthrax, and Ester formation is also read with respect to tularemia, where there will be a bite of the tick on the hand and there will also be a lymphadenopathy. If the bite of the tick is on the hand, he will develop axillary lymphadenopathy. If it's gonna be a bite on the leg of the person, there would be inguinal lymphadenopathy. So tularemia per se will always be a zoonotic disorder. This zoonotic disorder will also be called as ulcero because there was an ulcer on the hand due to the bite of the tick and there's enlargement of the lymph node, so we call it ulceroglandular fever. But in this particular case, you can notice the fact that lymphadenopathy is definitely present, but at the same time, there is no mention or there is nothing like neuritis and orchitis found in tularemia. The two presentation tularemia are the Ester on the hand and the lymphadenopathy and lymphangitis that is present. There is no neuritis, no orchitis. This was relatively a difficult question and is again a zoonotic infection that can come from unpasteurized milk, that is brucella. When you read the literature of brucella, remember the same condition which you read as undulant fever. The same condition where the microbiologist has taught you about Castaneda's method being used for culture. The clinical presentation of this can be what was given in the exam, that is gonna be apart from fever and lymphadenopathy. There's going to be two more features present, that is neuritis and orchitis. Whenever you are reading about orchitis in a question, two organisms that I always want you to think in terms of, especially from pediatric domain, is mumps, and from internal medicine adult perspective to be remembered is brucella. Answer is option number C for this question. Moving to the next one. The next question talks about a person coming to you with fever, prostration and rash on the extremities. You can notice the purpura. You can notice the petechiae which are present here, extensively present on the body of this guy. So the organism that you're thinking in terms of would be causing Waterhouse-Fridson syndrome. Well, Waterhouse-Fridson syndrome is going to be caused by which bacteria? It's bang on these four options. I think you can pick it up. That's going to be Neisseria meningitidis. The answer to this question is option number beta. Option A would cause anthrax, that is wool sorters disease. So you would find it again in hunters or in wool sorters. Francisella tularensis, as I explained to you, is gonna be ulceroglandular fever and was explained in the previous slide. And there has been a question on tularemia in the previous year, so do read about it from microbiology also. Moraxella catarrhalis can contribute to development of angular conjunctivitis. You read about this organism, the option number D, with respect to ophthalmology. When you're studying the topic of conjunctivitis, that is where you read about this one. The clinical presentation given in this question on the basis of the purpuras and the petechiae and the rash present is that of Waterhouse-Fridson syndrome. I mean, this is a nasty organism that can contribute to sepsis. Sepsis can cause DIC. I mean, the logic here is this bacteria, option number B, is causing sepsis. Sepsis is causing DIC, and DIC can contribute to bleeding manifestations. DIC is called as consumptive coagulopathy. So platelet count will also be less. Clotting factors will also be less. If both will be less, that is why the bleeding manifestations will occur in this patient. The next question talks about a fat lady coming to you with pain in both the knee joints. Obesity is anyway a risk factor for development of osteoarthritis of the knees, and this lady has not got surgery done. She has not even got a total knee replacement done. So there is a click sound coming from the knee joint. That is a crepitus that is being heard. The diagnosis of this case is very straightforward. It is osteoarthritis. The most common joints involved in osteoarthritis is the knee joint. Rheumatoid arthritis, option number A, as I've highlighted, will always cause involvement of the small joints. So that is why option A is ruled out. Ankylosing spondylitis will mainly contribute to sacroiliitis. It will always be a male patient and will always talk about low backache in a person. The joints that are involved is sacroiliac, so bamboo spine can occur, kyphosis can occur. Reiter syndrome is ruled out by exclusion. Why? Because this condition will be having features of arthritis with conjunctivitis and uveitis. Reiter syndrome is mainly related to sex tourism. Like this guy, he went to Bangkok, he had sexual exposure without using a condom. So this chap, when he came back to India, he started having arthritis. He could not see properly because of the uveitis component. He also had conjunctivitis, and more importantly, I mean, the fourth manifestation is he is not able to urinate properly. There's a burning micturition, urethritis. Reiter syndrome is what you see with chlamydia. That's one of the leading STDs, right? That can be acquired after unprotected sexual exposure. In this particular question, the two main pointers are one, the involvement of the knee joint, and second is the very fat woman. Both of these point to the fact that she's gone into osteoarthritis and would need a priority TKR, a total knee replacement. Otherwise, I mean, she will not be able to ambulate. She will put on more weight, and the more weight she puts on, again the damage. This is a vicious cycle. No, she can't move around, so she'll take a painkiller. Her kidneys gonna be affected. She's gonna keep on sitting at one place, so the weight will keep on piling, and the knees will undergo degenerative process. The answer to this question is option number D. Next question says, comment on the diagnosis. If you look at this girl child, you will notice a very characteristic webbing of the neck. This webbing of the neck, which is highlighted, will make the diagnosis as Turner syndrome. Another feature which is very characteristic in this image is short fourth metatarsal. I'll just write it down for your convenience sake, though this is very well mentioned both in pathology as well as in pediatrics, that whenever you read about short fourth metatarsal bone, it's gonna be a feature that is encountered with Turner syndrome. The answer to this question is option number C. The remaining options can only be worked out on the main word, right? I mean, if I just for record's sake write it, you are gonna see this image once, or you're gonna see a patient like this ever once in your life. You're gonna remember it forever. The answer to this question is option number C. The next question talks about a diabetes patient developing macrovascular complications. Retinopathy, neuropathy, nephropathy. Option number A, B, and D, which are present in this MCQ, are actually gonna be microvascular complications. If you listen to the discussion of diabetes mellitus, right in the first 15 minutes, I've handled this, that retinopathy, which will contribute to blindness, neuropathy can cause an ulcer in the sole of the foot, a non-healing variety, nephropathy will cause chronic kidney disease. They are all microvascular. What are the macrovascular complications in diabetes mellitus? There are two, CAD and PAD. Coronary artery disease will increase the incidence of myocardial infarction, and peripheral arterial disease in a diabetic patient will increase the risk of gangrene. Macrovascular complications are coronary artery disease and peripheral arterial disease, making the diagnosis of this MCQ as option number C. The next question talks about comment on the diagnosis, and obviously you could make up something which is the shape of the stomach. Normally, the stomach shape would be like this. You would have the greater curvature, the lesser curvature, then the pylorus, and then the antrum. But in this case, there is a gross distortion. See, there is definitely a nick in the greater curvature, you can see here. And at the same time, in these patients, even the lesser curvature, you can see something like a mushroom here. You can see something like a mushroom here. This is basically because this person here is having a gastric ulcer which is causing pyloric stenosis. In fact, if you have listened to the test and discussion part that I take, you will notice the fact that I've called this as niche and notch sign. I'll just write it for your convenience. On a barium meal follow through, when you read about niche and a notch sign, this niche and notch sign on a barium meal follow through is a feature that is always seen with gastric ulcer. Gastric ulcer always is associated with a lot of fibrosis that contributes to development of pyloric stenosis in the patient. A lot of people casually answered this, looked at this particular area and probably answered as esophageal varices. You see, varices cannot be visualized with help of a barium. You need an endoscopy for that. I mean, nobody will waste your time or his own time by doing a barium study for varices as of now. You would rather do a upper G endoscopy and would be spot on in your diagnosis. The answer to this question is option number B. Option number C and D, varices and menetritis disease, is best identified by upper G endoscopy. In menetritis disease, you have hyperplasia of the rugosities. Varices are obviously going to be veins that are going to prolapse into the lumen of the esophagus, so they can be visualized by upper G endoscopy. The next question talks about a child with complaints of urine turning black on standing. That's a standard presentation of alkaptonuria, homogentisic acid oxidase deficiency. And for management of this condition, you will be giving vitamin C and nitistone, because they are making the paper a little difficult. So you should also be aware of the treatment. So additional point that I've taught you is, what is the treatment for alkaptonuria? Well, enzyme replacement therapy is the ideal treatment, but that's gonna be horribly expensive. So to mitigate the cost factor, at least you can give these two, vitamin C and nitistone for alkaptonuria, homogentisic acid oxidase deficiency. A 3-year-old child presents with periorbital edema, foamy urine, and dipstick showing 4+ proteinuria. The moment you read about a child with 4+ proteinuria, you know that the diagnosis of this kid is minimal chain disease. Minimal chain disease is also called as steroid responsive proteinuria. The drug of choice for this condition is prednisolone. You give it for 8 weeks and it's goodbye to the disease. It's the same disease, no, that you read as having effacement of the foot processes of the podocytes, and because light microscopy will not reveal any finding, we are going to call it a nil lesion. So minimal chain disease per se or nil lesion is going to be treated with prednisolone. That is why we call it steroid responsive nephrotic syndrome. It has an excellent prognosis. We are next going to talk about a 2-year-old child who's presented with recurrent UTI episodes, which on culture was found to be due to E. coli. I mean, E. coli is one of the common causes for UTI. Please appreciate, whenever you read about a child with a recurrent UTI, the first differential diagnosis that you always have to think in terms of would be posterior urethral valves, which is a congenital malformation. This particular condition can even be messed up on a cystoscopy, because the position of the valves is such that the cystoscope, with a forward wing cystoscope, may not be able to see the valves. So what I will do is, I will give IV contrast to the child. make the child urinate, and when he's urinating, that is when we will take the scans. The test is called as MCU, that is micturating cystourethropy. The answer to this question will be option number beta. The next question was widely debated. The question talked about a smoker with occasional bouts of cough and progressive shortness of breath. The chest X-ray was done, followed by a bronchoscopy. 2 images were given. Well, bronchoscopy image, this is what I could get from my test and discussion batch. In the X-ray, you will notice that there is a distinct shadow present here, which looks like as if it's some kind of a cyst. And even on a bronchoscopy, you can see this white shadow here, which looks like a cyst that is growing into the bronchus. It is occluding the bronchus and could be explaining the symptoms of this person in the form of cough and shortness because the airway is narrowed. The best diagnosis for this particular condition is a hydrated cyst. Pulmonary TB is ruled out because option number A will mainly be seen in the apex of the lungs, and there's no apical presentation in this case, and there's no need for doing a bronchoscopy in TB. No, unless and until there is a hemoptysis, we usually do not do a bronchoscopy in a case of pulmonary tuberculosis, so that's why it is out. Most guys were confused between either a hydrated cyst or bronchogenic carcinoma. You see, bronchogenic carcinoma will always cause local destruction, whereas in this case you can see a round circumscribed shadow. This round circumscribed shadow could be a growth inside the lung, but the point is that whenever it's a growth of a cancer, it causes local destruction. Aspergillosis always causes production of a black color sputum. In fact, aspergillosis usually occurs in pre-existing cavities in the lung. So 2 options can easily be ruled out, that is A and D. You have to select between B versus C, considering that it was smoker given. A lot of guys thought, sir, why it can't be cancer? But as I highlighted before you, one, a circumscribed shadow, and secondly, you can see a white lesion growing into the bronchus, narrowing the airways. So we need to consider hydrated cyst. In fact, the second most common site of hydrated cyst in human body is the bronchus or the lungs. The most common site of hydrated cyst is the liver. No, the second most common site is the lungs of the patient. So answer to this question is option number B. And lots of questions hydrated cyst have actually been asked in your exam with respect to complications that can develop due to rupture into the biliary tree, or he has given scenarios of a shepherd having a painless hepatomegaly, and then he has come to you for a diagnosis. So you are evaluating the liver is relatively firm in consistency. So I mean, clinical scenarios are routinely given in your exam in paper 2, and well, hydrated cyst is one of the hot favorite topics of the examiners of MCI. The next question talks about fever with obstructive jaundice with increased SAP. Now, there is fever present with respect to biliary process. So what I want to tell you is, like, suppose this is the gallbladder, this is the cystic duct, and then it will unite with the common hepatic to form the CBD. What I want to tell you is that where the gallbladder is finishing and the cystic duct is starting, we have an anatomical area. This anatomical area that I've highlighted now is called as Hartmann pouch. Once you know the anatomical component, I now want you to understand that my patient is actually having not one, but multiple gallbladder stones of varying sizes. Like in red, I have shown multiple gallbladder stones, and one of these stones has stuck or lodged itself in the Hartmann pouch. Once the stone will lodge in the Hartmann pouch or maybe in the distal part of the cystic duct, it will cause obstruction because now the bile will not be able to flow. So that is why, one, there would be fever because this will cause gross distension of the gallbladder. In fact, it can rupture also. The person will present to you with right upper quadrant pain. There could be obstructive jaundice manifestations, and obstructive jaundice is always having an increased serum alkaline phosphatase. This presentation where the stone is impacted in the distal CBD or maybe in the Hartmann pouch is what is technically called as Mirizi syndrome. Hepatocellular carcinoma will not contribute to obstructive jaundice. It will cause a hepatocellular jaundice. Viral hepatitis will again cause increase of SGOT, SGPT. I'm ruling out option number B and C. Why? Because they will mainly cause derangement of SGOT, SGPT and not serum alkaline phosphatase. Cholecystitis does not contribute to obstructive jaundice. Obstructive jaundice can only be seen if there is choledocholithiasis, that is if the stone goes in the distal part, like if the stone goes in the CBD, we call it choledocholithiasis. But if the stone is stuck in the Hartmann pouch or in the cystic duct, then we call it Mirizi syndrome. Remember my words carefully, guys. If the stone is stuck in the distal CBD, it is going to be choledocholithiasis. But if the stone is stuck in the cystic duct or maybe in the Hartmann pouch, we call it Mirizi syndrome, where the person can present with acute abdomen. There would be fever, right upper quadrant pain, and obstructive jaundice manifestations can occur. The next question was a repeat one. He gave a peripheral smear in which you can definitely see these rings, like wedding rings, and lots of time you can see more than one also. Because of the fact that there are multiple ring stages present inside a single RBC, therefore the diagnosis of this person should be kept in favor of falciparum malaria. This image has been asked once again in the exam. In the previous sessions of the exam, they made it easy by incorporating a blue shadow like this that I'm drawing right now. I think all of you are familiar with banana-shaped gametocyte. So just like you guys are remembering that banana-shaped gametocyte is a feature of falciparum malaria, this time he removed that banana-shaped gametocyte just because he thought that, okay, he'll make it difficult for you. But you guys are brilliant chaps, you still cracked the question right. Multiple ring stage is gonna be a feature with falciparum. Answer to this question is option number beta. The next question talks about an elderly patient with signs of moderate dehydration and urine osmolality that is found to be low. Which of the following is a possible etiology? The key word in the question is low urine osmolality. That's always a feature with diabetes insipidus. SIADH will always be having water going back. You see, antidiuretic hormone will reabsorb all the water back in the body. So in SIADH, the urine of the person will be highly concentrated. Autosomal dominant polycystic kidney disease will mainly present with flank pain because there are cysts in the kidney. GFR will be less, so they will be higher in hypertension, and subsequently these patients will develop chronic kidney disease. It is diabetes insipidus which will have this presentation of low urine osmolality. Renal tubular acidosis will then have presentation of acidosis. No acidosis given in this question. The correct answer to this question is diabetes insipidus. Whenever you read about dilute urine, the first thing that you need to keep in your mind from exam perspective is diabetes insipidus. And well, this person developed this diabetes insipidus. Now this person is having loss of water from the body. There's polyuria, polydipsia. So because there is loss of water from the body, that will explain the dehydration component. He's not understanding why is he drinking so much of water. In spite of that, he is dehydrated because all the water is getting lost. And when you evaluated the person, urine osmolality low is one of the keywords that you always need to remember for DI. It could either be central or it could be nephrogenic. That will obviously be worked up on the investigation part. But the moment you read the statement that I've highlighted in the box, it means that diabetes insipidus is to be considered. In the next question, he's talked about a patient with previous history of myocardial infarction 3 years ago. Now is having tachypnea, tachycardia, breathlessness on crying stage, and third heart sound. So what is he telling you? Heart rate is more, respiratory rate is more. There is breathlessness on climbing a stair. So there must be some pulmonary edema component because he's talking about a heart getting involved due to MI previously. Third heart sound is always auscultatory finding of heart failure, congestive heart failure. The answer to this question is option number delta. Pericarditis, how am I ruling it out? Pericarditis will always be having presentation of chest pain, but in this case, there is no chest pain described. It is rather these examination findings of heart failure given. Pulmonary embolism is usually associated with deep vein thrombosis, and in this MCQ, there is no deep vein thrombosis. That is MI scenario, post-MI scenario. LV aneurysm can be a close differential diagnosis, but the point is LV aneurysm, I'll just draw it like this. If this is left ventricle, there is an aneurysm in the wall of the left ventricle. The presentation of aneurysm is that it can cause clot formation inside the aneurysm. And these clots, God forbid, if they go out of the heart, they will contribute to embolic stroke. So next time they give you a clinical question saying post-MI patient is going into stroke. See, he had a MI 2 years ago or 3 years ago. But now, because there is structural damage to the heart, the diagram is showing LV aneurysm. It is showing clots in the heart that are going into systemic circulation. So post-MI patient developing a stroke in future, then the reason why a post-MI patient will develop stroke is LV aneurysm. But in this case, there is no stroke. It is only features of sympathomimetic stimulation, and third heart sound is one of the very good pointer. Third heart sound can either be heard physiologically or for that matter of fact mainly is pathological, right? Pathological with respect to congestive heart failure. I mean, I cannot call S3 physiological in a setting of MI. If somebody has already had MI, if S3 is present, let me say in pregnancy, I can still be, thinking, okay, a lady might be anemic, she might be progressing into heart failure. Is it physiological? I can still think that. But S3 in a setting of MI is always to be thought of as pathological. The answer to this question is option number D. The next question talks about a 30-year-old man presenting with myoclonus and sudden onset dementia. What is the most probable etiology? Please appreciate whenever you read about myoclonus and sudden onset dementia, the presentation is due to consumption of beef. This person has consumed prion particles Due to consumption of prion particles, he will be developing an abnormal protein in the cytoplasm of the neurons that is called as PRPSC protein. This presentation will cause sudden onset dementia in a young chap. Normally, you read about dementia in 80-year-old man, 30-year-old having dementia. I've highlighted that in the app. At 30-year-old man having dementia, you always need to think in terms of an infectious etiology, and that is called as variant Creutzfeldt-Jakob disease. This is also called as prion disease. I repeat once again, 80-year-old man with dementia, Alzheimer's disease. But a 30-year-old man having dementia, that's not a normal thing, no. This is mainly related to eating of contaminated beef. This is mainly with respect to consumption of tainted beef. So therefore, the person had these manifestations. The answer to this question is option number C. The next question was a very interesting one. Only one student of mine from PrepLadder, she was able to recall the entire question. So let me just speak it before you. She said that the question was on a patient with pleural effusion, and the pleural effusion was tapped and the pleural fluid protein was evaluated. They evaluated the pleural fluid protein, which was 2.4 grams, while the serum protein was 6 grams. Pleural fluid LDH values were given. So what are they trying to test here is they are trying to test your knowledge of Light's criteria. Well, Light's criteria are used to evaluate a transudate versus a exudate. How do you know it is a exudate or how do you know it is a transudate? You will basically calculate the ratio. In the numerator, you will be taking the pleural fluid protein and LDH values. So let's put up the pleural fluid protein in the numerator. And in the denominator, you will put the serum protein and you will calculate the ratio. If this ratio turns out to be, I'll just show you a table here. If this ratio turns out to be less than 0.5 and 0.6 respectively, then it's gonna be transudate. 0.5 for proteins. So let's do it for proteins and see whether it's 0.5 or not. The numerator here is 2.4. The denominator is gonna be 6. So I definitely can say the fact that mathematically speaking in this case now, the value will be something like 0.4. So it is less than 0.5. Less than 0.5. You don't need to even waste your time calculating the LDH values in the patient because it's a gross wastage of time. You've already cracked the question. The pleural fluid protein divided by serum protein values turning out to be less than 0.5. You can see here that in case the value is less than 0.5, it indicates it is of transudative etiology. And which of the following is a transudate? Well, that is congestive heart failure. I would suggest you to listen to the pleural effusion discussion where I have talked about the Light's criteria in detail and I showed you a slide here also. The transudative pleural effusion is what is present here. Option number B is the answer to this question. Option A, C and D. They are all examples of exudates. If they're exudates, then you will notice the fact that the protein ratio will be more than 0.5 and LDH values will be more than 0.6. You don't need to calculate LDH values because proteins is anyway giving you the diagnosis. Option A, C and D are exudative pleural effusion. Option number B is transudative. How do I know it is transudative? This ratio that I just calculated before you was a difficult one. I definitely agree. If you could not crack it, no issues. Don't be bothered about it. Nobody is expected to solve questions like these. The next question talks about a center line being put in a patient. He is asking you what is the best method to confirm whether it is inside the jugular vein. Well, please remember if you're putting a center line and whether it's gone in the jugular vein, you can do an X-ray. Ideally, when you are putting a center line, ideally you should put a center line always ultrasound guided. Ideally, a center line should always be put ultrasound guided. Why? Because I don't want to puncture the carotid artery. But suppose like in government hospitals, you do not have facilities like these, then I want you to understand that at least when you put the line, you need to do a check X-ray to know whether the line has not contributed to pneumothorax and it is not causing damage to adjoining tissues in the neck. The correct answer to this particular question is option number A. You see, blood pH will not help you identify vein versus artery because pH is standard in both the vein versus artery. Color of blood can be very subjective, no? Color of blood can be subjective. If the person is put on oxygen, even the venous blood will look red to you. Suppose a person is very sick. Normally, hospitalized patients are sick. In a sick person, if you're gonna give oxygen, even the venous blood will look bright red to you. So, color of the blood can never be telling you it's arterial versus a venous blood. Pulsatile flow blood can definitely be artery. EtCO2, that is mainly to check the position of the endotracheal tube. No? When you intubate somebody in advanced cardiac life support, to check endotracheal tube position. Suppose the exam, and this has been asked in anesthesia in your exam, if you want to check the endotracheal tube position, then you can check for EtCO2. But the correct answer to this question is option number A. The next question talks about an adult patient who is presented with a pulsatile swelling in the neck below the angle of the jaw. It is producing an expansile impulse. It's outward impulse. What is the probable diagnosis? Normal phenomenon. Yeah, you do have pulsations in the neck, but the pulsations are at the base of the neck, no? In this condition, where is the location? The location is at the angle of the jaw. The location is not at the base of the neck. I repeat once again, the carotid artery pulsations, like if you're sleeping, the carotid artery pulsation can be seen at the lower part of the neck. So option A is ruled out because of the location part. Parapharyngeal abscess, you see pulsations are always present in a vascular tumor. The vascular tumor in this case would be a carotid body tumor. This is common carotid artery. This is external carotid, this is the carotid body, and then is the internal carotid artery. I've just highlighted the basic anatomy here. You see guys, the carotid body is present anatomically sandwiched between the external and the internal carotid. The person is having a tumor of this carotid body. It will produce a pulsatile mass in the neck. The correct answer to this question is carotid body tumor. Cystic hygroma is a cystic lesion and is commonly found in children with Turner syndrome. I showed you an image of Turner syndrome today already. You have seen the webbing of the neck. So additional finding to be remembered is cystic hygroma is seen with Turner. This was a spot diagnosis guys. AIDS positive patient with features of meningeal irritation, neck rigidity present tells you about fungal meningitis. You can see the India ink preparation here. You can see the capsule. You can see that there is a definitive shadow of the capsule. So we are talking about a capsulated organism on India ink, and that's gonna be Cryptococcus neoformans, and you are gonna give liposomal amphotericin B for this condition. The answer to this question is option number A. The next question was a spot diagnosis. You can notice a greenish brown ring in the periphery of the eye. This is gonna be KF ring. KF ring is what you read with respect to Wilson disease. For management of this condition, zinc acetate would be used, and D-penicillamine can also be used as a chelating agent. The main highlight of this MCQ would be the greenish ring or brownish green ring present in the periphery of the cornea. The next condition was having a blue sclera. Blue sclera is a presentation of osteogenesis imperfecta, a spot diagnosis again. Owl-eye appearance of cells in urine is a finding that is seen with cytomegalovirus. You are aware of owl-eye appearance two times, no? Lymph node biopsy and owl-eye appearance with respect to urine microscopic examination in a post-kidney transplantation patient, because this organism will cause graft failure. With respect to lymph node biopsy, I want you to remember that the diagnosis is Hodgkin's lymphoma, and for this would be an infection which will contribute to graft failure. Cytomegalovirus is a nasty organism. It can cause graft failure in a post-kidney transplantation patient. That is why lots of time you will give ganciclovir prophylactically to patients of post-kidney transplantation so that they do not develop this opportunistic infection. The next question that I'm discussing will be discussed by the forensic consultant, but even I am speaking about it because I just wanted to highlight this very peculiar term, storm of catecholamines. Storm of catecholamines is what you read either with a scorpion sting, or that can cause hypertensive crisis. You might have to use prazosin or other alpha blockers for management. But apart from storm of catecholamines being seen with a scorpion sting, I want you to remember that this can also be seen with bite of a black widow spider. Black widow spider is what they show in a mafia movie. In Hollywood mafia movies, they will show that mafia boss and he's releasing those black widow spider in the house of somebody, and that person will die. I mean, that's again a catecholamine surge that will cause hypertensive crisis. It can even contribute to brain hemorrhage. The next question talks about a patient arriving in shock. Which cannula will you be using? You're familiar that in a person for shock for resuscitation purposes, when you give IV fluids, you will be using either a 14 to 16G cannula for the patient. Do remember the fact that when it comes to 14G, that would be an orange one, and 16G would be the gray cannula. Option number A and B cannot be the answer to these questions because they are normally used for giving maintenance IV fluids to the patients. Green cannula or pink cannula would be also used to give blood transfusion. It is just that the green cannula is used in a male and a pink cannula is used in a female, but for shock it would be orange versus gray. Now what to select for this question? Then I would suggest you to answer this as option number delta, though I'll leave it to the surgeon to give a final answer for this one. You see why I'm saying the gray cannula is because the textbook says that orange cannula is very thick. So only those who have taken special training of ATLS, only they are equipped to handle and insert a orange cannula. Otherwise it is waste of resources. So for routine doctors, for people like you who have seen limited cases, if you're resuscitating a person with unrecordable BP first time in your life, I would not like you to waste the orange cannula. I would like you to rather utilize the gray cannula for the patient. The answer to this question should be given as option number delta. The next question showed an X-ray of a pneumothorax patient. There is definitely a shift of the trachea to the right hand side. This is left, this is right. So you can see a tracheal shift. You can see in the X-ray of this patient there is absent vascular marking. So the chap is actually having left-sided pneumothorax. So if a person will have left-sided pneumothorax, you can see the right side of the chest, the lung markings can be seen, but the left side, the X-ray is looking more black than normal because there is air at positive pressure in the chest. This is the lung border, this is the lung border, and the rest is being compressed by the air at positive pressure where I put the plus signs, and there is no lung in this area, so absent vascular markings. So what are you going to do in this case? You're going to put in a chest tube on the left side of the patient. So treatment of choice for this particular chap who's having a left-sided pneumothorax will be to insert a left-sided intercostal drainage tube. In tension pneumothorax, you obviously put a wide bore needle first and then put in a chest tube. But he's not asking you even about the wide bore needle. It's just inserting a chest tube, get rid of the pneumothorax of this person. And pneumothorax will always contribute to, the tension pneumothorax will always contribute to trachea to go to contralateral side. The answer to this patient is, or MCQ is option number A. Coming to the last one, a HIV positive patient is presented with these lesions. Some people even said that white lesions were present in the mouth of this guy. That is obviously natural because candida will occur. In this particular patient, he's having features of Kaposi sarcoma. We get Kaposi sarcoma when the CD4 count of the person tends to become less than 200. You see, when you talk about the stages, in stage 1, obviously the CD4 count will be usually normal. In stage 2, it will be something in the range of approximately 200 to 500. But as the CD4 counts will start to fall, that is when opportunistic infections and lesions like Kaposi sarcoma can occurring in a patient. Stage 4 is where full-blown AIDS will occur, and that is when the CD4 count might become even less than 50. So Kaposi sarcoma usually tends to appear. It can appear even at CD4 count of less than 50, but most of the time would be encountered in the later part of the illness, that is stage 3. The answer to this MCQ is option number C. I shall be now explaining two ECG based questions that came in the exam, and I personally feel that they were relatively straightforward. In this particular image, as I will zoom in, you can notice that it is a broad complex tachycardia. Let us quickly discuss the heart rate. Heart rate is RR interval. That's going to be 300 divided by the number of large squares. Now you can see here that the number of large squares would be something in the range of 1.5, which means that the actual heart rate of this person is 200 per minute, which is disproportionately fast. You will notice that this person is having a broad QRS complex, which makes the diagnosis very easy. If you look at option number A, ventricular fibrillation, it will be having twitching activity, so it is ruled out. Whereas option number C and D both will be having a narrow QRS complex. In fact, in the app, I have discussed precisely how to hand draw the ECGs. If you just invest 15 minutes, I'm just saying just 15 minutes of your entire lifespan, if you invest into listening to the ECG component that I have hand drawn before you, especially the tachyarrhythmias component, you would be bang on spot to diagnose the tachyarrhythmias that are asked in FMG, NEET PG, or even a USMLE exam. The correct answer for this question will turn out to be option number beta, ventricular tachycardia, which is characterized by broad QRS. And also, as a next step, in case he repeats this question in the next exam and he says that the blood pressure of this person is unrecordable, you will have to give DC shock to the patient. But suppose the BP is recordable, something like 90 millimeters of mercury. So I'm saying BP is low, but at least it's recordable. No, then you will be giving IV amiodarone for management of this patient. So I just want you to remember broad complex QRS tachycardia mainly asked in the exam is monomorphic. Monomorphic because all the size of this QRS complexes amplitude is almost equal. So monomorphic VT is the diagnosis here. I also want to bring in a fun fact here. In fact, one of my students, looks like a girl's hand only, I had posted this actually on my Insta account. This girl, she was putting up henna, that is mehendi, and at some festival, right, close to Diwali. So she actually drew the ECG designs with the henna on her hand. You see, pretty innovative, right? I mean, she's drawn ventricular tachycardia, precisely what I'm talking about, Torsades de Pointes, ventricular fibrillation. So I just thought that I'll show you this image to look at the creativity of people. Like, you know, she's putting in henna and she's still studying at that particular point of time. That talks about dedication that we doctors have, that even at the time of festivals, we are actually trying to revise what is present in our mind. I also want to highlight the fact that most of us, you see, and lot of us, including myself, when I'm watching, or let me say, I am scrolling on Facebook, or I am watching any video on Instagram, or I'm watching a video on Facebook, it actually contributes to release of lot of dopamine, and lot of dopamine, when it is released, it gradually causes addiction. So you can see a guy here watching Netflix, like they say Netflix is addiction. So most of the time, these low yield tasks can be like watching a movie. Low yield tasks can be like just scrolling through Facebook and checking out what other people are doing. I mean, people are going to post about their breakfast, lunch, and dinner, and we are looking at the picture and feeling happy. But you guys are a class apart. I want you to appreciate that when it comes to studying, it's always going to cause less dopamine release in the brain, which is the reason why we tend to start feeling sleepy when we are studying. And because we are sleepy, we'll just dump the books and we'll start spending time and whiling our time on Facebook, and that causes wastage a lot of time. So though this is an exam discussion, I want to highlight the fact that you need to mentally train yourself. I'll highlight the word train yourself. You need to do this mental orientation of yours where you can focus on the core issues. I mean, you need to set a reward system for yourself. You will be allowed to watch Netflix or high dopamine release activities only when you have completed the low dopamine ones. So when you wake up in the morning, the first thing you want to do is do low dopamine related tasks, so that subsequently you can reward yourself with a high dopamine task. This was just an offhand remark from my side, and we come to the next question, which talks about a person having a narrow QRS. You can see that literally the QRS complex is jumping on each other. In these circumstances, you will now have to see these abnormal looking waves which are present before the QRS complex. Well, we call this a classical sawtooth pattern, and therefore the diagnosis of this person will turn out to be that of atrial flutter. You can obviously rule out ventricular fibrillation because it will be twitching. Ventricular tachycardia will have a broad QRS complex, as I've explained to you, and atrial fibrillation will always be having absent P waves. But in this case, you will notice any wave which is present before the QRS complex is either a P wave or is a sawtooth wave. In this case, you can see not one, but as much as 3 sawtooth waves present before every QRS complex. So therefore the diagnosis of this person will turn out to be option number D, which was again a very straightforward one. But my humble request to you would be that if you can just hand draw these rhythms that I'm talking about, not on your hand but on a piece of paper, and just stick it somewhere. Every time you're going to move around, right, and you're going to look at these ECG rhythms, they will stick with you. And most of the questions that are asked are very, very scoring, guys. ECG is very easy to the level that these technical people, these technicians, they are not as qualified as you are. They may be 10th class or 12th class people. Even they are able to analyze the rhythms because they see it regularly in the hospital. So because of the fact that a technician can do it, obviously you guys can do it because you are a class apart, guys. Your mental level, your capacity, your ability to remember things is much, much, much superior as compared to, I would say, a technician or a medic in a hospital. So 2 questions on ECG were asked, which are very simple and very straightforward. Please keep on reading as much details as you can. Keep on hammering, guys. Keep on learning more and more facts on a daily basis, because as you know, paper 2 is definitely a tiebreaker. I mean, that can differentiate between a good score and a bad score. I would suggest you to focus especially on medicine, surgery, OBGY. Obviously, all subjects are important, but they should definitely be given the necessary importance. Most guys tend to focus on other subjects, neglect these, and I usually find that because of that, a lot of people might actually be having suboptimal scores. These are the details from my side. Thank you for your patience, for hearing me out for such a long duration. Bye-bye. Take care.